It's a pleasure to be with you. The title of this talk is Influenza Immunizations in College and University Students. There are no disclosures for this presentation. Objectives include review the current status of influenza vaccination rates and risks in college students, review results of the Phase 1 and Phase 2 studies of college student influenza vaccination programs, discuss cultural concepts that apply to college vaccination strategies, review the 4 critical success factors for college vaccination programs, review recommendations, and briefly discuss the University of Rochester's experience. Much of the content of this talk was adapted from the National Foundation of Infectious Diseases webinar, Increasing Influenza Immunization Rates in College Students. This slide presents some key points that underlines the importance of influenza vaccinations in college students. We know that annual influenza vaccination is the best prevention against influenza. College influenza coverage is only 8 to 39%, much less than the Healthy People 2020 goal of 70%. College campuses are high risk for contracting and spreading influenza due to high-touch activities and frequent social events. Motivating college students to get immunized is a challenge. Students who initiate influenza vaccinations in college tend to continue with vaccinations after graduation, thus helping to set healthy patterns for adulthood. Northeastern colleges have higher student vaccination rates than schools from other sections of the United States. In 2017 to 2018, Weill Cornell Medicine received a National Foundation of Infectious Diseases grant to help study influenza immunizations in college students. There were 2 phases to this study. Phase 1 was a quantitative study based on a survey of 1,005 undergraduate college students 18 to 24 years old to assess student attitudes toward influenza vaccination and barriers. Phase 2 was a qualitative study of college and university health service providers to assess their experiences with influenza vaccination programs on campus. The main goal of this study was to identify best practices to improve influenza vaccinations in the college population. Let's start with the Phase 1 part of the study, a survey that assessed student perspectives. This slide demonstrates student attitudes regarding influenza vaccinations. 51% of students were not concerned about getting influenza, and 59% felt it was unlikely that they would get influenza in the next 12 months. Yet some studies have shown influenza attack rates as high as 73% on college campuses. So students have a misperception of the personal risk of being infected. Yet even with those attitudes, 70% felt it was important to get an annual influenza vaccination, though only 46% typically get an annual influenza vaccination, which may imply a perceived access issue. Students generally have a good understanding of the disease, but poor understanding of the vaccine. 93% know that flu affects all ages, and 91% that influenza causes complications of pneumonia, sinus infections, and worsens chronic medical conditions. Yet, regarding the vaccine, 59% believe the vaccine causes the disease. 51% believe the vaccine causes the virus to mutate and develop resistance to future vaccines. And 35% believe that they will get the flu by being vaccinated. This slide reviews barriers perceived by students and includes: I don't need it, 36%. I don't like needles, 31%. Doesn't work, 30%. I'm worried about risks, 27%. I forget to get it, 24%. I don't have time, 16%. I don't believe in vaccines, 13%. It's too hard to get, 7%. I don't know where to go, 7%. I can't afford it, 6%. Or my insurance doesn't cover it, 3%. The barriers outlined in yellow are likely associated with student knowledge of the disease and vaccine, including concerns about risk, don't believe in vaccines or that they don't work, forgetting to get the vaccine, and a greater concern about needles than the real risk of the disease. This knowledge gap could be addressed by enhanced vaccine information delivered through appropriate and diverse information channels. Several barriers were associated with access issues, including those outlined on this slide. I don't have time. It's too hard to get. I don't know where to go. I can't afford it. And my insurance doesn't cover vaccines. Adequately addressing these access issues will likely help improve student immunizations. Additional student perceptions of access and incentives include: provide vaccine at low cost or free, 61%. Provide monetary or other incentives, 60%. Provide vaccines at multiple locations on campus, 48%. Friends and peers receiving and recommending vaccines, 42%. These would be horizontal communicators. Holding fall health clinics to provide influenza vaccinations and education, 31%. Providing students with reminders via email or text, 26%. Having campus celebrities receiving and recommending vaccine, 18%. These would be vertical messengers or communicators. The four top suggestions being providing free or low-cost vaccines, provide incentives, provide vaccines at multiple sites, and peers as examples and recommending vaccines. Notice the difference between the perceived importance of celebrity and peer support for immunizations. 18% for campus celebrities and 42% for peers. This demonstrates an important basic concept of cultural communications and community engagement: the difference between vertical and horizontal communications. Vertical and horizontal communications relates to the cultural concept of class and status. All societies have elements of class and status. Generally, there are three social classes in each community: upper, middle, and lower. Class is associated with certain attributes and is fairly well defined. For example, a person living in a section of town may be associated with a certain social class. Certain jobs may be associated with class. For example, a physician or lawyer may be considered upper class in some communities, where other jobs may be associated with the middle or lower social classes. Vertical communications occurs when a person of a higher class communicates with individuals of a lower class. This would be like the campus celebrity from a higher campus class communicating on influenza vaccinations to middle and lower campus classes. Superimposed on the class system is a status system and roles. These statuses are found in each class of a society or community. In each class, there are individuals of higher and lower status. Status is the social position assigned or achieved by an individual. Role is the acting out of one's status. Every member of a society or community has his or her statuses and roles. A man may have a status of son to his mother, physician to his patients, and elder in the church. In each of these statuses, a person is expected to fulfill certain roles or behaviors. Generally, people want to interact with people of equal or higher status and seek to move up in status with every opportunity. With that last statement in mind, a person can generally only significantly impact those of equal or lower status. Influential individuals are located at the upper end of each class in a society or community. These individuals are informal leaders, also known as horizontal communicators, peer communicators, opinion leaders, influential individuals in class, and champions. The reason they're known as horizontal communicators is due to the incredible influence they have on people within their class. These individuals have exceptional ability to change the beliefs, values, and resultant behaviors of those in their class, but equal to or below them in status. This is demonstrated by the yellow arrow in the diagram. Individuals of high status in their class communicating with those of lower status in their class. These last few slides point out a complexity of community engagement. Appropriately engaging horizontal communicators in each class of a target community. Failure to appropriately engage the right messengers may result in program failure. Both horizontal and vertical communication is important for successful community engagement in changing risky behaviors. Communication from a higher class to lower class vertical communication generally results in high prestige, low message volume or capacity, and low persuasion potential. This would be like utilizing a movie, music, or a campus celebrity like a football or basketball star as a messenger. Public information officers often seek out these types of individuals since they have broad name recognition, yet realize that these celebrities will only have marginal persuasion potential. They often suffer from silver spoon syndrome. Comments often heard include, "They don't understand the reality of life in my situation. It's nice that they care, and I respect them for that, but they don't totally identify with my needs." Low to higher class communication, we'll call reverse vertical communication, is generally poor, associated with low prestige, message volume, and persuasion. Horizontal communication is generally associated with moderate prestige, but high message volume and persuasion. The utilization of horizontal communicators is a major tenet of true community engagement. Finding well-respected individuals of high status within their class who can effectively communicate horizontally within their class. Horizontal communicators are often informal, not formal leaders, and therefore often not effectively engaged and used in community engagement programs. These horizontal communicators have incredible potential to influence community and individual behaviors, and if not appropriately engaged, can undermine community engagement in a target area. So the results of the student perceptions are not surprising and support the cultural communications concept of vertical and horizontal communications. I would like to underline that vertical and horizontal communications are both important, though realize that there is greater persuasion potential in peer horizontal communicators. Once again, the 4 top student suggestions for improving influenza immunizations being providing free or low-cost vaccines, provide incentives, offer vaccines at multiple sites, and utilize peer horizontal communicators. This slide lists more specifics about student-suggested incentives, including free food on the top of the list at 31%. A big campus influenza event in the fall with free food, free or reduced cost vaccine, live music, an opportunity to meet campus or other celebrities, those vertical communicators, get influenza information, and generally have a campus meet and greet party. Bookstore discounts were next at 13%. Holding a raffle for gifts, 11%. A school health day with extended influenza clinic hours, 8%. Opportunity to give back, 8%, though I'm not sure what this all entailed. In-school competition was low at 2%. So, intra-school competitions may not be of great interest to this current college generation. So free food, holding a fall big campus influenza event represented 57% of the students' suggested incentives to improve campus influenza vaccinations. This slide outlines decision influencers for students choosing to get the vaccine. The greatest influencers being in decreasing order parents, guardians, family members, followed by healthcare providers, having a student healthcare center on campus for access, and peer or horizontal communicators. Note the incredible influence parents, guardians, and family have on health-related decisions of students. This is not surprising when considering the cultural communication concept of primary message systems. Parents, guardians, and family members were of greater influence than the internet, traditional media, and even social media in this study. Notice that vertical communications, including public figures or on-campus celebrities, were not very influential, as expected from our previous discussion. There are 3 general ways or levels to communicate messages in humans. These levels are part of the human primary message system. The first level is the formal level. This is essentially trial and error. Unfortunately, having to use the trial and error process is often dangerous. In health messaging, we try to avoid this way of learning. For example, a person may learn by personal trial and error that smoking actually causes cancer after smoking for 20 years. That message was too late to prevent disease. Second is the technical level. This is essentially a lecture format where a teacher presents information and tries to convince or persuade students to accept and believe the information delivered. This is one of the most common communication tools of traditional public health. Third is the informal level. This utilizes the innate desire of people to imitate role models. These role models may range from parents and family members, peers or horizontal communicators, community leaders and celebrities, etc. Experts contend that a great part of culture, including values and worldview, are communicated at the informal level versus the formal trial and error or technical teacher levels. For example, children learn early basic language skills via imitation of parents, family, and community members as they speak. This took place outside of awareness in the subconscious. Later, language learning was reinforced and refined by the technical level via teachers. Edward Hall's most important counsel is that if we want to introduce changes, particularly in basic beliefs or behavioral patterns of a culture, we must introduce, or at least mightily reinforce, at the informal, out of awareness level. If this is true, Much traditional public health communications to change high-risk behaviors may not be focused at the most appropriate level, the informal communications level. The informal level of communications is targeted by community engagement programs through the personal actions and behaviors of horizontal communicators. Community engagement also utilizes horizontal communicators at the technical, informal teaching level. Once again, the technical level of teaching is more effective when reinforcing what is being learned at the informal imitation level. Sequencing is important. Informal level followed by the technical level of learning seems most effective. This is an example of the importance of informal imitation level learning, demonstrating the family influence on tobacco use reported in the MMWR in 2001. In that study, 34.5% of high school students and 15.1% of middle school students used tobacco, yet 70% of middle school and 57% of high school students who currently smoked lived in a home where someone smoked cigarettes. Smoking of students was markedly higher in families that smoked. Peer pressure wouldn't likely explain this observation. Transfer of messages and meaning, whether good or bad, is more effective in many instances through the family and relates to the informal imitation level of learning. This was also demonstrated in the student influenza vaccination study. The example and recommendations of family members significantly influence health behavior decisions of students and young adults. So the major student influencers to get influenza vaccines were family members, healthcare providers, access to campus student health centers, and horizontal peer communicators. Let's now consider the Phase 2 part of the study that considers the student health services perspective. The Phase 2 part of the study involved 10 colleges and universities in 5 regions of the U.S., including the Northeast, Southeast, Midwest, Southwest, and West. 6 schools were private and 4 were public. The study sought to identify influenza program efforts at each school and their successes and opportunities for improvement. All schools felt that they were doing well with their influenza immunization programs. The study identified 4 critical success factors, including 1. Prioritize vaccination clinics, 2. Emphasize the importance of staying healthy, 3. Use diverse partnerships and communications channels, and 4. Make influenza vaccinations and prevention a year-round effort. This slide lists some tactics for prioritizing vaccination clinics, including locate the clinics in high traffic areas across the campus, schedule clinic hours to match student schedules. Several schools use one big event followed by multiple smaller clinics throughout the influenza season. Practical examples would include one big 2-day kickoff event at the end of October, 1 or 2 pop-up flu fairs per week during flu season located in a high traffic area of campus, and 4 or 5 whole-day flu events scattered throughout the fall. Free immunizations also helped uptake. Next, let's consider a few comments about emphasizing the importance of staying healthy. Remember that in the Phase 1 student survey, the most common reason for not getting an influenza vaccination was not needing the vaccine, since many students felt they were basically healthy. Only 49% of students were concerned about getting the flu, though as previously mentioned, some studies have shown influenza attack rates as high as 73% on college campuses. Many students felt the influenza vaccine was only needed for those who had other chronic medical conditions. When asked about activities students thought were important to stay healthy, balanced diet was on the top of the list, followed by regular exercise and regular medical checkups. An annual influenza vaccine was in fourth place of 5 options, with only 39% feeling it was very important for staying healthy. It's interesting that the most common reasons given by students who actually get vaccinated were, I do not want to get sick and I want to do everything I can to stay healthy. The other two common reasons for getting vaccinated were, it's part of my yearly routine and my doctor recommends it. Somehow, the message of getting the flu vaccine annually resonated with this segment of students who elected to get the vaccine. Why and how did that happen? We don't know for sure, but it may relate back to information on the decision influencers slide. The influence of parents, guardians, and family members, previous counsel of healthcare providers, and/or peers or horizontal communicators. This is a quote from a student health professional during the study. I think the message, "This is how you stay healthy so you can go skiing," or "This is how you stay healthy so that you can take your midterm," is more effective, because these kids don't think they are ever going to get sick, become seriously ill, develop complications, or die. Students are interested in current or present impacts on their lives and the things they want to do, not necessarily that something like influenza could be fatal or cause long-term complications. Youth commonly feel invulnerable, and that often leads to risky behaviors. Youth realize people die, but believe it will always be someone else, not them. This is partially explained by different cultural worldviews of time for students and older adults. Let's briefly consider those different worldviews of time. This is a cultural egg diagram adapted from G. Linwood Barney's Layers of Culture. The yellow arrow represents the concept that our values, institutions, and behaviors result from deeper cultural influences. At the very center of this cultural egg rests our worldview or deep beliefs. These beliefs can be divided into 4 major categories: our beliefs about ourselves as human beings, nature, the supernatural, and time, the past, present, and future. The next 2 slides briefly discuss the different worldviews of time for adults and students, and how that understanding can help inform messages to encourage influenza vaccinations in the student population. Generally, adults and students have different worldviews of time, as represented by circles representing their perception of the past, present, and future. The size of each circle portrays the relative importance of each aspect of time. To many Western adult cultures, the past or history is somewhat important, informing and providing information to improve how things are done in the present. The future is very important for adults in this worldview, since most adults realize that decisions in the present, like saving money for retirement or receiving influenza vaccinations, can significantly impact the future, including quality of life and even life itself. In this worldview, with a large future circle, primary prevention, including activities like getting annual influenza vaccinations, makes sense, doing something in the present to impact the future. Other worldviews, including those of students, often perceive time differently. Generally, the student culture in the United States would likely draw the present circle large, with smaller past and future circles, focusing primarily on the present. Most students are concerned about relationships, being together, events, enjoying the present. Messages that focus on current student benefits and interests, like how influenza vaccinations can impact skiing during the Thanksgiving break, going to the fall dance, or allow successful completion of the midterm examinations, will likely be more effective than emphasizing more distant future benefits. Understanding the student worldview of time, with a focus on present interests and concerns, helps explain why influenza vaccine messages suggested in this quote make sense. Understanding the various aspects of cultural diversity is important for public health practice. This applies to not only the obvious cultural differences between ethnic groups, but also the subcultural differences as demonstrated by the different worldview beliefs of students and adults just discussed. Cultural diversity training is essential for public health practice and leadership. Diverse partnerships and collaborations are important to increase student immunization rates, including partnerships with internal campus groups like resident life groups, dining services, other campus student groups and associations, and athletic departments. External partners will also be helpful, like state and local public health, healthcare systems, pharmacies, medical professional training programs, parent groups, etc. Public health is well positioned to facilitate these partnerships between internal and external groups. To do this effectively, public health leaders would greatly benefit from training in technical, adaptive, and boundary-spanning leadership, coalition building, and facilitation skills and competencies. These topics are covered in more detail in other sessions of the North Dakota Public Health Training Network. Communications must be broad to reach all students and reinforce accurate and consistent disease and vaccination messages, and may include websites, social media, newsletters, signage, parent publications, parent events, mascots, student group communications, influenza survival kits, and competition messaging, etc. The communication strategy includes engaging public information experts from participating groups and saturation of all communications channels with culturally appropriate, accurate, and consistent messages. More in-depth discussions of cultural and general communications concepts are covered in other sessions of the North Dakota Public Health Training Network. The fourth critical success factor is make influenza vaccinations and prevention a year-round effort. This relates directly to a quality improvement process that includes planning, implementation, and evaluation. In the spring, planning takes place. This is the time to bring together and establish internal and external partnerships and develop a strategic plan that will include a comprehensive communications plan, vaccination clinic, and evaluation strategies. In late summer, communications implementation starts with orientation of students and faculty to the year's influenza vaccination plan. The communications clinic and evaluation strategies are implemented in the fall and winter during the influenza season. In the early spring, the evaluation and analysis of data is completed, providing information for the upcoming spring planning effort for the next year. Public health leaders should be well trained and experienced in quality improvement. Quality improvement will be further discussed in other sessions of the North Dakota Public Health Training Network. Major barriers encountered by college and university student health programs included partnership and collaboration problems, inadequate resources of time, funding, and personnel, student apathy and feelings of invulnerability. The registration process was the rate-limiting step. Students under 18 years old need to have parental consent to receive flu vaccine. Posting consent forms on the university website was helpful. Clinic flow can also be a problem. Separating faculty and staff in one line and students in another may help logistically. The student line may need to collect copies of insurance cards and benefit by having an insurance specialist on site to work these issues. Faculty and staff may not need that process since they are likely covered by the institution's insurance plan. The goal would be to complete the whole process for a student within 5 to 7 minutes. These barriers should be anticipated and addressed during planning in the quality improvement process. Not all issues can be prevented, but must be addressed as encountered through an ongoing effective group or partnership process. Colin Powell wisely stated, "No battle plan survives engagement with the enemy," meaning that any plan will need to flex and adjust to conditions as they arise. Partnerships are essential for an effective student influenza vaccination program. Viable and functional partnerships must have an appropriate relationship base, or they will fail when conflicts arise. Relationship strength is emphasized in the concepts of boundary-spanning leadership that are covered in other sessions of the North Dakota Public Health Training Network. During planning, the partnership identifies their mission or vision, develops a strategy, identifies group norms and values, and develops specific tactics or what each partner is to do. After planning, it's time to implement. Implementation often results in conflict. The partnership leader's role is to facilitate cohesion within the new group. A suggestion would be to take adequate time to develop enough relationship strength before moving on to implementation, if at all possible. Building cohesion is not a one-time event, but a perpetual process. Team building activities help, including things like field trips and socializing events, providing time for this intergroup to develop solid relationships, feel good about being a member of the group, and become emotionally engaged with each other. Strength of relationships is essential to help groups weather the inevitable conflicts and tension that develop as boundary-spanning groups address adaptive problems. Let me underline that patience to develop adequate relationship strength is important for boundary-spanning success. Don't rush this process, or boundary spanning will fail when conflict arises. Study recommendations include: 1. Provide accurate and culturally appropriate information to a wide variety of groups, including students, particularly providing information about the vaccine; healthcare providers, encouraging them to discuss influenza vaccine at the pre-college visit; parents, realizing that they have great influence on students getting a vaccination; peers, or horizontal communicators; and campus celebrities or vertical communicators. 2. Utilize the quality improvement process, including adequate planning, developing strategies for communications, clinics, and evaluation, implementation of vaccine strategies, and evaluation identifying successes and areas needing improvement. 3. Provide appropriate incentives like free food and vaccinations, big campus events, and bookstore discounts, etc. 4. Develop key partnerships, internal and external. A key external partnership is with parent groups. Other recommendations include have a default plan in place. For example, for students who forgot their insurance cards, etc., give the shot and follow up later. Standing orders from the state health officer are useful. These would generally apply to those over 18 years old. There should be a clinician on site to handle emergencies. Schools without health services, like community colleges, should consider networking with pharmacies, local public health units, and other outside providers to provide these vaccinations. This slide summarizes some key practices used by the University of Rochester Student Health to improve student influenza vaccinations. They utilized an annual mass vaccination exercise with partners, including state health department programs, including emergency preparedness and response program, immunization program, the local public health unit, campus resources, including the field house for space, public safety for traffic control, public relations for communications, facilities for tables, chairs, and waste management, information technology for computer support, student health services for clinical personnel and electronic health records. Another resource used by the University of Rochester was the Alana Yaksik College and University National Flu Vaccination Challenge that helped the university organize and participate in an intercollegiate influenza vaccination challenge. Alana Yaksik was a young woman who died of influenza. To find out more about this vaccine challenge, Google Alana Foundation. Student health service clinic activities included added an immunization prompt to their electronic health record, posted signage in waiting rooms, and asked patients about flu shots with each visit through March. Collect insurance data in advance of the clinical visit. It helps if the school has a requirement that all students must have health insurance that covers immunizations. Communications. Announced influenza vaccination clinics to students, staff, and faculty weekly. Posted clinical announcements on the university website bulletin board. Sent a set of PowerPoint slides on influenza vaccinations to faculty to show before each class, and posted large signage in key campus sites. This slide lists the University of Rochester results. The mass vaccination exercise increased the number of students immunized by 30% versus non-exercise large clinics. In 2017, utilizing a mass vaccination exercise along with multiple small clinics throughout the season, 24% of the student body were immunized. They still have a long way to go to reach the Healthy People 2020 goal of 70%, but have made progress. In summary, student influenza vaccination rates are far below the Healthy People 2020 benchmark. Students lack accurate knowledge, particularly about influenza vaccine. Effective partnerships based on relationship strength are essential. Culturally appropriate communications to key stakeholders are necessary, and utilize a quality improvement process.